epidemiology, especially his work on breast cancer epidemiology. And I'm sure many of you feel this way, that of course, since Bob's death in 2012, Bob is really still greatly missed for his tour de force intellect, his exceptional teaching skills, and so many of the other contributions that he made to the department, the school, university, the community, his work with breast cancer advocates, and how he touched the lives of so many students and colleagues and friends. And so we're committed to honoring Bob's memory in several different ways. This annual seminar is one of those. Those of us who work on the Carolina Breast Cancer Study are committed to making sure that's the best possible study and carried on as long as we can, since that was such an important project for Bob and for breast cancer research. And I'm sure each of us remember Bob in a number of small ways as well. So I'd like to acknowledge the support of the Millikan Tribute Fund and, of course, the Lyme River Cancer Center for supporting this seminar. It gives me great pleasure to introduce this year's speaker, Dr. Beth Terry, who braved weather. How many hours were you at LaGuardia last night? Much person time at LaGuardia to get the last flight out to Greensboro, and a 1.5-2 hour cab ride talking politics from Greensboro. So you survived that in the middle of North Carolina. So we really appreciate your determination and perseverance to be here. So for those of you who don't know Mary Beth, she's a professor, Department of Epidemiology at the Mailman School of Public Health, Columbia University. She received her MA in economics from the University of Washington and her PhD in epi from Columbia. And I think, as all of you know from her work, she's an internationally recognized leader in cancer epidemiology, particularly breast cancer epidemiology, integration of epigenetics, biomarkers, the life course perspective, and that really embraces a broad territory, but it's really produced some very impactful research. She's, I think this is something she's going to be talking about today, has been able to leverage, as all good epidemiologists, a number of important studies, cohorts of high-risk patients, the Long Island breast cancer study, a number of other studies that really she's effectively utilized for her research. Her portfolio includes over 200 publications, numerous awards, study sections, important committees. She teaches the Advanced Epidemiology Methods class at Columbia, right, as well. And we really appreciate you, again, spending all that time to get for what is otherwise a 1 hour or so flight and coming in last night and meeting with our folks today. So let's welcome Mary Beth.
Thank you very much. I'm deeply privileged to have been invited to give this lecture. It was totally, I would have spent even more time just to come here. It's quite an honor. I was introduced to Bob through my doctoral advisor, Millikan, about 20 years ago. She had us to her house for a lovely dinner, and since then I've been so inspired and have greatly admired all of the work of Bob. So I remember that night speaking to Bob about all of his work and training in veterinarian science and how that influenced his career, and I was very inspired with how he developed his career from there. And we spoke, the first person I ever worked with in epidemiology was Elizabeth Sonnenschein, and she did the first ever, maybe the only ever, case control study of mammary tumors in dogs. And I always remember that she said the hardest thing about interviewing dog owners after their dogs passed from breast cancer was to talk to the owners and how grieved they were, and how she found that harder than interviewing men after their wives were diagnosed with breast cancer. So I remember talking to Bob about that. But I'm a dog owner myself, and so I understand a little bit more about that. So in any event, it's a great privilege to be here, and I'm quite nervous giving this talk in front of all these wonderful methodologists in the room, but here goes. Okay. So what I'd like to talk about mostly is in thinking about really what we sometimes might say is epidemiological heresy, which is going after the most selective, least generalizable populations. And so part of this, you might say, is pure opportunistic behavior on my part, but that's really, I guess, part of epidemiology as well. So, I mean, these are cohorts that we have been following at Columbia now for about 2 decades. And so I'm hoping by the end of the talk to convince you that we can learn a great deal from these very high-risk populations that's highly relevant, I would argue, to average-risk women as well. Okay, so just to start out, first, the title was, I was told you always have to make a title to bring people in, so the title was meant to be controversial, and so I will just state from the top that there's many situations where obviously population-based approaches are really completely sufficient, in case control studies in particular are the hallmark features that they're the most efficient kind of design. And in many ways, if they can be executed, really are sort of the best design because they can capture the complete exposure period throughout life, which sometimes cohorts are incomplete with capturing exposures moving forward and backwards. So the design itself is a very useful design, and particularly when we want to generalize to all cases. And case control studies really have that advantage that they really do have complete capture of all ages if designed that way, whereas cohorts really, by design, are picking up the earlier cases first. And Martha Slattery talked about this as a very important reason for thinking about some of the differences between cohort and case control designs. Can you hear me in the back? Okay. So there's, however, practical issues with conducting case control studies these days. And the students, we had an interesting conversation about this about an hour ago, among other things we talked about. But you know, it's just very challenging, particularly in the U.S., to do true population-based sampling of people unaffected. But there's really this theoretical issue, and this is what I really want to center on for today's talk, which is when we do try to capture a more generalizable population, we may not have enough precision for the tail of any one distribution. And it's really maybe that tail where we can get a signal that may be relevant to the whole. Okay? So scientific philosopher Herbert Spencer said that civilization is a progress from the indefinite, incoherent homogeneity toward a definite, coherent heterogeneity. So you can also say that epidemiology is really this, right? So everything, you know, there's lots of terms that are used, you know, precision prevention, you know, public health, precision prevention, all of these things. But really, it's getting at this kind of heterogeneity that we all know exists. And it's trying to find those subgroups of people that either can be targeted for specific interventions and or can just inform in terms of ideologic investigations in terms of how our environmental factors interact with our genetic factors. And so if you can think of really the contrast, what we really want to do, obviously, is have the greatest impact with the most number of people, and that would be moving the whole distribution. So I'm not arguing that this is not a useful approach, but what I really want to say today is mostly let's focus on this tail and how what we can learn about what's going on here may then be relevant for risk assessment here, and then may be relevant for ideologic reasons. So just to kind of start out with you know, a broad way of thinking about this, if we think about the prevention continuum, no one argues here, this is really where precision medicine is with the tertiary prevention, that really, you know, there's some interventions that can be applied to the whole, and there's some that should just be targeted. And this has really been the success of targeted treatment, particularly for breast cancer over the past several decades. But the same thing can be done with secondary prevention and screening. Obviously, screening works if population based access and everyone has it, but then the frequency and when you start it very much does rely on targeted approaches of finding out who is at highest risk. And you know, this whole idea of over-screening, particularly with CTs, you know, it's estimated in any 1 year, there's about 25 million CT scans that get done in the US that are not needed. So this idea of targeting those who can benefit the most is really also very much embedded within screening. And then of course primary prevention, there's obvious kind of ways and things to target for for breast cancer, if you think about risk-reducing surgery as well as chemopreventive agents, those all have to be targeted. But even thinking about lifestyle interventions that really should apply to the whole, the reality is guidelines may not be enough, and so targeted lifestyle interventions really then, who do we find, who do we target to get those kind of interventions, even though we want to give the guidelines and everything to everyone. So, there's many examples where population-based approaches for prevention are incredibly useful, but then there's also many examples where you need more targeted approaches. So my talk then is in 3 parts. So first to talk about design aspects. Second to talk about analysis. As epidemiologists, we all lead with design, and we follow up with analysis. And then really to give a few examples. So again, the examples will come from both risk assessment and etiologic kind of questions to say, can we learn something from the tail that's relevant to the complete population? So can we learn something from high-risk women that's relevant to all women? So first, we need to define the tail and how we're going to get there. And so, this is something that's not new at all in epidemiology. One of the major ways for defining who's at high risk has been family history. And so it's not just cancer, although every cancer has a component like this, but it's cardiovascular disease, it's asthma. Most chronic diseases all have a family component. That family component is a huge relative risk. So huge being, once we say we're above 2, it's huge in epidemiology. But keep in mind, these are still average effects. So this is, when we really think about it, these 2-fold, 3-fold, 4-fold associations from family history actually means to see that in a population means that any individual has a much, much higher risk, absolute risk from this than that average is even showing. So 1, it's big. 2, it applies to a whole lot of diseases. So we need to pay more attention to it. But we stopped paying attention to it, I would argue, because the idea has always been that family history equals genes. Not so much within epidemiology communities, but generally. If there's patterning of disease, at least in many medical communities, the idea must mean it has to come from your genes. But of course we know, from twin studies and everything else, that it's shared environment as well as genes. We know now, that there is a lot of utility in collecting family history information. So the pie chart here just is a very simple overview of how we kind of think about most chronic diseases and certainly cancers, which is there's a group here, and this kind of piece of the pie would be anywhere from 5% for some cancers to as much as 30% for some others. And this is really thought of as the sporadic, if you will, cases. And then, of course, the idea has always been, well, if this is where the bulk of the cancers occur, this is where our attention should occur because we care about reducing the bulk of disease. So I do not disagree with that. I'm just saying that maybe we can still learn from this group that's still applicable there. And, over the years, there's been a lot of causes of cancer. Causes of cancer are quite diverse. There are bacteria, there are viruses, there are behavioral factors, there are hormones. Nobody would debate most of these, if not all of these. The main evidence came from case control studies. And most of these, all of these actually were all observational studies that found those. And they were all done in average risk populations. Okay? So again, we can learn a lot from studies of average risk. In contrast, for this group, have mostly been attacked by doing family-based studies. To find the genes, to do gene discovery, you do family-based studies. And now, of course, there's hundreds of genes that have been found over the several decades, all from these family-based studies initially, right? And again, all from observational studies. So our causes of cancer, whether they're genes or environment, come from observational studies. And what I'd like to argue is the genes that we have learned here that we found in family-based studies have been completely relevant to all individuals. We know that BRCA1, for example, can be methylated in average risk populations with women without a family history. So I would like to, in the same way, argue that what we learn from this group of family-based studies and from families that are high risk about the environment could also then inform So if you're willing to accept what we know to be true, which is the genes that we find through family studies are very relevant for average risk, then, if you will, take the extension with me to say, and to see some of the evidence of where we can get environmental signals from this group as well. So what we've been doing over time then is trying to look for what's explaining risk within our high-risk registries. And so just to give you a broad picture, the Breast Cancer Family Registry, which most of the data I'll show you today comes from, really, even though they were specifically recruited for gene discovery at the time in the mid-90s to find BRCA-X, and even though they were recruited with very high-risk criteria, so you either had to be diagnosed under 44 or have multiple affecteds within your family and or have male breast cancer, you know, even all of that, BRCA1 and 2 only is present in about 10% of our individuals. So BRCA1 and 2 is still pretty rare even within high-risk individuals and families. So of course, then what else can explain this? So over time, we've been focusing on, with my colleague Regina Santella and pre-docs that we both trained together, on a variety of different biomarkers. The area that we've spent probably more time on has been DNA repair phenotype. But again, using kind of a case-control design, but a case-control design within a family. So the affected member is a sister with breast cancer, the unaffected member is a sister without breast cancer. And we found a number of different biomarkers were relevant in predicting which sister had cancer, but again, this was all retrospective. So now we're following up on many of these findings in a nested case control study in the cohort. But back to the environment. So if we think about smoking, and Ebony, I know you're focused on smoking for your dissertation now. So here, these are the very high-risk women. This is a study that was published about 10 years ago now with the Breast Cancer Family Registry. So you can see on an absolute risk that smoking too is very relevant even within these carriers. And you know, there's been a debate back and forth for some of the retrospective ascertained cases, but now prospectively too, I'll show you some data, we're seeing a signal for smoking even within the carriers. So then if we have to think about approaches of which way to go, here I just illustrate with a figure from the Million Women study. So we can look for gene-environment interactions in average risk populations. It's sometimes harder to see a signal though. So, and obviously these are pretty precise signals because they're, it's a million women. But you know, what has been shown, not even just in breast cancer, but a lot of cancers, is it's sometimes hard to see gene-environment interactions. And I would argue one of the difficulties is when you take cases that have a very wide range in ages, it may be harder to detect the signal. So again, our approach is really in the high risk. So there's you know, always been this kind of trade-off anyway if we think about sort of randomized clinical trials, you know, between inference and generalizability. So we've always had this sort of willingness to forego population ascertainment approaches in, you know, in favor of trying to think about contrast and designs for inference. And so what does the family cohort help you with? So here is just some illustrations of different cohorts. So the two that I highlighted here, these are two family cohorts of breast cancer. So this is the NIEHS sister study and then our breast cancer family registry. So they're both designs where they recruited people once there was at least, in the sister study, you just had to have one first-degree relative that had cancer, a sister. And in ours, as I mentioned, it's a little bit more high risk, but it's still similar design. But what you can see is, unlike some of these other cohorts, if this is the average follow-up time of how many years you have to follow the cohort, and this is the size of the cohort, and here, this one's the multi-ethnic cohort, this is the French E3N cohort, this is the Women's Health Initiative, and this is the Nurses' Health Study. These, if you will, more average risk cohorts, they have a smaller percent of people who have any family history, okay? So, you know, these are large cohorts, so they still may have, you know, precision to say something about an interaction between any family history and no family history, but any family history, as I'll show you in a minute, is still a pretty heterogeneous group of people. So, and whereas these family-based studies, obviously by design, they have a a lot of family, all family history. So here is our cohort here. So this is the Breast Cancer Family Registry, and then we teamed up with another high-risk cohort, which also recruited during a similar time period. So this is about 18,000 women, and this x-axis here just says their lifetime risk. So this is calculated from a pedigree model. We used the Bodicea model that was developed by Cambridge, and so this is a probability going from 0 to 1, and if you use, for example, the National Comprehensive Cancer Guidelines, they usually say, average risk, a high risk would be 20% or more. Average risk is somewhere here highlighted in pink. So even with this family design, we have a spread of absolute risk. And so why does this occur? Because if you think about families, right? So we have families where you have second degree, third degree, you have cousins in here. And so again, by design, we didn't just recruit people based on a first degree relative. So you have a spread, but see how many people we have in what would be called average risk. So if we use this 1 in 8 number, we have plenty of precision for average risk. We also then, by design, have some precision for this tail. Okay? So the concept is, let's use this kind of family-based design both to inform us about what's going on at the tail, but also to really kind of show a contrast between the two and ask, do these things have different effects in average risk versus high risk? So Bob's written so much that has really highly inspired all of our work, and this one paper, and he's gone on with colleagues too to advance this even further. One paper that was very important from a public health point of view was to really show that lactation could reduce the increased risk